Now we will have on the parallel session here, on the parallel session, lean cost management, adopting lean-oriented analytical methods with Nick Katko. Major will be there. And here on the main stage, we have two doctors, Dr. Javier Sala and Dr. Federico Pinto. They will be talking about maximizing the efficiency of a surgical center. So welcome, doctors. Lean doctors.
Thank you, Thompson. So, well, it's my pleasure to introduce a great friend of mine, an amazing doctor. Dr. Javier Sala is the founder of the Lean Institute Argentina, is the CEO and adjunct CMO of the Instituto Modelo de Cardiologia, that it's a model of a lean organization in Cordoba, Argentina. He's also a renowned physician, a renowned researcher, but he is a great speaker as well. So please, Dr. Javier, welcome, and the stage is yours.
Well, so good morning, good afternoon, good evening, maybe good night. It depends on where you are in the world. Thank you very much. It's a pleasure to me and an honor to be here with you, Dr. Fred, a dear friend and a colleague. And of course, very important for us to be able to share the work we do here in Argentina, okay? So just to get started my presentation, please let me know if you're able to see my screen.
The screen is okay, yes. Not the presentation. Great. Yeah.
Sounds great. All right. So 12 years ago, okay, we started our lean journey in our hospital. And it has been an amazing journey. Okay, we're very excited about the things that we have done and accomplished, and we are looking into for more years to come. Our organization is located, like Fred mentioned, in Argentina, in Cordoba. It is the center of the country. It's called Instituto Modelo de Cardiología. We have more than 50 specialties. It's not only cardiovascular. And we were founded in 1977. Okay, we have 72 beds. It's a type of boutique hospital. And we admit more than 7.4 thousand patients a year and receive more than 250,000 outpatient visits per year. One important thing for us to mention here in this presentation is that it is a private institution, but we do not have capitation. We do not have our own insurance company, a health insurance program. So either the patient selects us, okay, as their provider, or we will disappear, which is actually very important for us to keep, improving. Another thing is that we were selected as an International Center of Excellence by the American College of Cardiology back in 2019 due to several work we have done in cardiovascular service lines like chest pain, cath PCI, and also heart failure, being the first institution accredited outside the US as an institution for acute heart failure treatment. And most importantly for us, it has been the lean work that we have been doing and actually creating the Lean Institute Argentina, which is incubated in the hospital, and now working with other companies trying to help them on their lean journey. And as mentioned before, we're part of the Lean Global Network and very excited and happy for that. So our philosophy as an institution is that first comes the patient, second comes the patient, third comes the patient and the patient's family. And we strive for personalized healthcare through teamwork. And our number one goal is to improve patient care. So why is it important for us to talk about the surgical journey, or how can we have a great a center? It's because for the patient it's very important. We all know that a patient's journey through the surgical procedure is very stressful for their family too. So we also know that for organizations to build up an OR is very expensive. We know that to maintain an OR is very expensive, and also the operations, okay, are also very, very expensive. You can actually measure in dollars like $125 a minute in most of the hospitals in the US, to just give you an example. And of course, if you work with bundled payments or have capitation, as efficient as you can be, it is very important to be able to treat your patients as soon as possible. So what are the goals, okay, with an operation with a surgical center? Of course, we always have to have as a fundamental basis that you need to add value to patients and family. That has to be also always the first thing to do. Having that in mind, you need to always constantly improve efficiency. So all the pre-op patient evaluation needs to be done timely, and you need to do exactly what's needed, no more than that. We need to increase capacity, okay, in the OR to be able to reduce the waiting list for patients. And also, you need to be able to eliminate delays for surgery, for scheduling a surgery. The ORs need to be also available for surgeons, okay, to be able to operate their patients, but due to necessity. And here I mentioned necessity and not desire, because usually you can have, surgeons asking for more operating room time than what they really need, and we can discuss that a little bit through the presentation. It's very important to manage also supplies very efficiently through in the OR. The OR turnover time. So once a patient leaves the OR until another one comes into the operating room, it's very important to have that as efficient as possible too. The first case needs to always start on time, because if you delay the first one, usually you are delaying the rest of the day. So the rest of the patients will also be delayed. And you actually need to have the maximum OR utilization. So a high OR utilization makes, the efficiency, okay, increase. And what is very, very important, you have to have motivated people, staff need to be a satisfaction of the staff need to be really high too. And, as efficient as you can work and more organized and more standardized is the happiness of the team is going to be increasing. So during this presentation, I'm going to be focusing on two different areas. The first one is the surgical area supplies, and also the patient flow through the OR, and how can we actually optimize OR utilization. So let's first focus on what we did, because actually at the beginning, when we started looking into our OR supplies, we actually thought it was very important to have every OR supplied with a lot of things inside the OR, and that the OR staff handled it, okay? The staff also were in charge of stocking, ordering, and also the reposition of everything that was needed for every surgery. That actually, when we started looking into if that was actually the best thing, we found a mismatch between the real stock and the digital records. And it was no surprise. You have here pictures here of the way we actually were keeping our inventory. And this created an increased frequency of requests for supplies, because the pharmacy, central pharmacy was called many times during the day to be able to bring supplies to the OR, because the supplies in the OR were not actually, the way we thought they were. Also, the lack of standardization of the list for every surgical procedure was also was a problem, because we actually didn't know exactly what was needed for each surgery, and the way they prepared for surgery was based mainly on who was preparing for that. Another thing was important, that our feedback from the staff was that they had too much work to do, because like I mentioned, they were managing the stocks, they were actually not well organized in actually ordering the supplies. They did have a date during the month that they had to order, and there was a date also established for the pharmacy to provide all these supplies. But the problem was that that was not enough, because our inventories were not well kept. So that's what actually made us, have several requests during the day to the pharmacy to bring more supplies to be able to work efficiently during the surgical procedures. So they had also to do surgical instrumentation and also the OR preparation for surgery. So the staff were not satisfied, saying actually they had a lot of work to do. And most important thing, they also needed to do the billing, okay? So we had delays in billing, sometimes even weeks, okay, to be able to know exactly what was used for the surgery. So was this unique to us? And actually, I just want to show you two pictures from friends that sent me from Brazil, actually, the way they managed their stock this is an OR cath lab in Brazil in a very, very prestigious hospital. And this one is an anesthesia machine in the US from another anesthesiologist, a good friend of mine that sent me these pictures. And actually, these are very current this year. And you can see that we were not the only ones that actually had the stock, we thought that it was in the right way, but probably there's a lot of room for improvement in these two hospitals in other countries too. So our goals were to have an efficient OR product supply management and billing. So we asked the central pharmacy, okay, to create a pharmacy inside the surgical rooms. We reduced the time to prepare the surgical purpose, the surgeries per procedure. So actually, this actually reduced the turnover time, okay, time between a patient leaving the OR and another one coming into the OR. We implemented Kanbans for stock management. Of course, we did 5S before that. And we implemented also KPIs such as percentage of stock and monthly order numbers to show improvement. Because it was very important to have buy-in from our people, are we improving with the work that we're doing? And the other thing was, let's just do just-in-time billing. So same-day billing right after each surgery. So the actions that we took in a nutshell were we created Kanban implementations to reduce the stock, avoid expiration, and also had a good signal for refilling, okay? This also took us for surgeons to work with the head of the pharmacy, looking into medical records for the past year to look into exactly what was needed for each surgery. So we did a retrospective analysis, and we looked into how much disposable medications, etc., were needed per surgical procedure for the anesthesiologists and also the surgeons. And we designed these kits, okay, specifically for each type of surgery. At the beginning, we created 8 kits for anesthesia and then 44 for surgical, for the surgeries. But right nowadays, we have 16 for anesthesia and 142 because we have been doing PDCA after we started. And the other thing is that we wanted also to have, like we mentioned before, turnover time optimization, okay, via an efficient procedure preparation. So let me show you what was before and actually what it looks like now. So it did look somewhere in some parts of the hospital or the OR that, things were organized. But if you look at it right now, you can see that we have 2 bin Kanbans method there. And you can see why did we do this? Because we have 1 week of stock per bin. And after you use that bin, it's empty and it goes, right on the upper shelf. Then it's the signal for it to be replaced. The other thing is that we actually looked at these pedetic diagrams to be able to look into each surgery. For example, this is an example of a cholecystectomy, how many steps, okay, it took us to be able to prepare for that surgery and how much time. You can see that it took 84 steps and also 18 minutes to look for all the material that was needed for this surgery. And after we did, the central pharmacy with all these kits, we could reduce the steps to 30. But the most important thing, we reduced the setup time to 6 minutes. And you can see, if you look into all the OR centers, you can see that this is a very common surgery. Okay, so this is one of the surgeries that most of the centers do. So you're able to reduce that. You are able to be able to allocate more surgeries during the day. So what were the results of the OR pharmacy? We were able to reduce our stocks inside the OR area, 96.7% for surgeons and 96.8% for anesthesia. And the OR area stock was reduced by 53%. The OR stock in relation to the central pharmacy stock was decreased from 14% to 8.7%. And the OR orders that I was mentioning that we had several calls during the day went from 30 per month, okay, to 4 to 8 per month. So that allowed the central pharmacy to work more efficiently, be disturbed less, and of course, the OR work better and not needing to interrupt or actually call, the central pharmacy to provide supplies. And the billing right now is done right after each surgery by the OR pharmacy personnel. So one of our pharmacists actually, mentioned that the OR pharmacy lean implementation allowed us to improve the quality of care, establish dispensing standards, and a rational use of stock, reduce costs, and strengthen the role of our pharmacists in healthcare team. So this is the team that actually took into the challenge of creating this OR pharmacy, and we're very excited and happy for them. So I want to recognize them. The other thing that I wanted to talk about was, how did we improve patient flow? So in this second part, what I want to share with you is how we actually looked at the map and we mapped the process of the patient. So once the patient is checked in, okay, it's transported to the wards, and there we have physical examination and we do medical history of the patient, and then the nurse prepares this patient for the surgery. So we started looking into these different steps. Once we call the patient from the OR until the patient is transported and he goes into the OR, which we call patient wills in. Then we start anesthesia, and then we start the first incision. We do the last stitch, and we end the anesthesia. We wean the patient from the anesthesia. The patient leaves the OR, so his OR wills out, and we check the patient into the PACU. Then the patient leaves the PACU. If you actually track all these different steps, you are able to look into the time in between them. So since the patient is called to wills in, the pre-anesthesia time, the induction time, the first incision to last stitch, the anesthesia recovery time, the pre-wills out, the wills in and out, which is the turnover time. So if you're able to look at all this information, okay, you are able to improve and decrease all type of waste that you have in between all these different steps. For this, we put together a software, okay, to collect the data. And for example, here we actually select the type of intervention. It's a surgical intervention. Where is that taking place? It's actually taking place in OR1. We look into what we have in the agenda. We select the patient. And once you select the patient, you have the right information to start the process. And we call the patient and start tracking each of these steps until the patient wills in, and all the ones that we mentioned before until the patient leaves the OR. So if you do that, you have a good database to be able to analyze with a business intelligence platform that will give you a lot of information for you to be able to improve. So for example, here we look into, are the surgeons using or not their blocks? Are the surgeons doing surgeries outside the block that is assigned to them? What is the OR occupancy in detail? Did the first case start on time? What about the second one? What about the third one? Is the surgeon and anesthesiology performance, compared to other groups? Can we actually look into what is the best type of match between a surgeon and anesthesiology per procedure? What does the process map tell you in time since the patient is called to wills in, pre-anesthesia time, induction, first incision to last stitch, anesthesia recovery, pre-wills out, turnover time? So all this information and more is collected and looked into with a business intelligence platform. And you can actually select this by type of surgery, date of surgery, type of department, or surgical group, type of anesthesiologist, who's the surgeon, type of anesthesia that was performed, which period. So this is very, very rich in information for you to be able to manage and have data-driven decisions. So the initial findings when we started looking into our data was that surgical groups were without blocked assigns. Blocked assigns were without use. We had excessive time between surgeries. We also had the beginning of the surgeries delayed. We had transportation time for patients excessively long, and also times reserved for surgical groups that would have no patients. Also, time for personnel that had nothing to do, and time for personnel that had a lot of work to do. So actually, this was very, very important for us to do staff to demand. And to give you just a good example of what the software does for us right now is to tell us, what we have here in the left column, the first one is, the number of the surgical departments. And then we have the block utilization in percentage per days, then the block utilization in hours, and then the hours used outside the block. Based on all this information, it tells you exactly if the group needs to keep the block, they need to increase the block hours, decrease the block hours, or maybe reassign a block and reduce the block hours like you see in the group number 11. So this is very important for us because we look into this data every 90 days and we are able to decide based on data what is the best thing to do to improve efficiency. What were the actions that we actually took after looking at the data? We reassigned blocks as needed by surgical groups. We assigned continuous block of 4 to 8 hours per team. That's the most, I would say, usual thing that we do. We review, like I mentioned before, data every 90 days. And we established the concept that if you book in advance, it's okay. But if you don't book in advance, you will release the block for other surgeons to be able to occupy those spots. We do staff time to demand, like I mentioned before, so then you don't have, areas where you have people not doing anything, and then people having a lot of work to do. And we assign 75% of the OR, okay, time for procedures that are programmed. 25% are for either, delays that could happen or also emergency that can come. We analyzed the cause of delays, starting each surgery, and we actually looked into reducing excess time on every step of the process. It's very important to target the first case starting on time for the rest of the day to be able to be efficient. So after doing this, after taking into account all this information and making all the changes that we needed, we were able to decrease in 8 years from 2016 to 2024 by 33 minutes on average per procedure. And if you remember, I mentioned at the beginning that, why is this important when you're talking about costs? For example, if you think that I just mentioned before that you have $125 a minute, if you multiply that times to 33 minutes, and let's say you do 5 surgeries per day in an hour, if you put that in an annual reduction, it's about $5 million that you reduce in costs, which is a lot of money just for 1 hour. So what we were able to accomplish in our case was at the beginning, we had our OR set up for the surgeons, for them to be able to do surgeries from 7 a.m. to 10 p.m. because this was based on the surgeon's desire. And we were able to accomplish a decrease in hours from 7 a.m. to 6 p.m. So for example, 900 hours in 2014 was our operating time. Now we have 560 hours. So 38% reduction in the time that we have our ORs open. One of the 3 ORs that we have is reserved now. If it's necessary, it will be open. And we had a staff reduction by 10% if we compare our OR right now to our ORs in 2014, so 10 years ago. All this actually is really a lot of cost reduction. We were able to do that by increasing 50% our number of surgeries if we compare these past months of October 2024 to October 2014. So our productivity increased and our cost decreased. And this is only, I would say, achievable and also possible if you really have lab data analysis to perform root cause analysis of where you have waste to be able to make the process lean. So just a few key learnings of our journey. The lean cultural transformation for us has been invaluable. We have no doubt about that. The C-suite is very, very happy with all the things that we have been accomplishing, and they support this transformation 100%. Our journey, we know that the lean is an amazing driver to accomplish safe, better patient care, and also efficient use of resources that we just saw. Every hospital that adopts lean substantially and continuously improve. There's no doubt about that. And leaders need to be embracing the cultural change. It's very important for that, for them to be actively involved in the transformation, for the transformation to occur. And we actually think, and we're sure about this, that the healthcare organizations need to adopt a lean culture in order to add value to patients, providers, the entire health system, and also payers. So having said that, thank you very much. And Fred, I don't know if there are questions, but I'll be more than happy to entertain, whatever questions the audience or you may have.
Oh, great presentation, Javier. Yes, there are a few questions. And I think that I will start with the third one, that it's a very, very tricky question about how, yes, it's from Vietfo Negin, and how do, I hope it's right, the name. How do you prevent external sources of uncertainty in your OR planning, like no shows, emergencies? So dealing with uncertainty.
So dealing with uncertainty, that's a great question. I think that, what you can always try to do is to do a predictive analytics. Okay, so based on your history, based on what had happened in the past, you look into your data and you can actually extrapolate that for the future. So basing your retrospective analysis of how things have occurred, most of the time, you will find that will still occur in the future. So you can actually use that to predict what can happen in this uncertainty.
Great, great. There's another one about, do you feel that being a private organization has facilitated the implementation of lean principles? And so if yes, to what extent? So if you're a private organization, it's easier to work with Lean.
I would actually is in our case, I would say that there are two major things. One is that being private and being small, okay, has two advantages in that case, because we don't have a huge board and the board doesn't change over time, like you usually see, for example, in public institutions. So I would agree that it was towards our advantage that we are boutique in a way and that we are private. But having said this, at the beginning, not all the board members were, I would say, excited about, doing Lean, because they thought that probably, that's not for healthcare, or that was not going to be able to be accomplished. So it is still a challenge, but I would agree that we probably we had an advantage by being small and being private.
Great. We have a lot of questions, but I would say that, I work at most of my time in public healthcare system. And I think what really makes the big difference is about the people. And we got great people working in the public healthcare system as well. So that's a challenge. But Sara Aranha, she's asking, did you had any challenges with surgeons' engagement, and how did you overcome these challenges?
And that's a great question. Of course, there was a big challenge to have surgeons, embrace the change. I think that the most important thing was that when we decided to make changes, we had to make surgeons participate. So we created actually a committee. And in that committee, we had the chief of the departments, surgical departments, that had the most, I would say, surgeries. For example, in our case, it was traumatology, general surgery. We had the physicians, cardiovascular surgeons, very important, vascular surgeons. So the head of all those departments were participating, and also the head of anesthesiology and the head of the OR. So all these different persons were part of this committee that was looking into how can we improve, efficiency in the OR. And that actually drove, I would say, the attention of all the rest of the surgeons. Okay, so it was very important to have them involved, to be able to have them have buy-in. But also we asked them to collect data, and then we analyze the data. So they were actually collecting the data that we were analyzing. And that is also important because they actually knew that the data was correct and we had to change.
So there's another question here from Pratek about how do you collect the data? It's manually or is automated during surgery?
Okay, so we have the software installed in tablets, okay, and would you just punch a button, okay, that actually starts every step, okay. So usually the circulating nurse is the one that is actually asking for the patient, and then collecting these different steps, and then the software analyzes the data automatically, okay.
Great. I think that we have time for one more question about, is the pharmacy Kanban relying on an electronic visual management system or is a manual one?
It's actually a visual management system, yes, and it's manual, yes, it's not electronic. Yes, but of course, everything that goes in the kits are inside bundles, okay? So all these bundles are also in the system. So every time you actually say, okay, this kit that goes for this surgery, the system already knows exactly what is inside that kit, and actually it decreases the stock, or, whatever is brought back from the surgery that was not used is put back inside the stock. So yes, the Kanban is visual and it's manual, but it's connected with the digital records. So we have a good, relationship between them.
We're running out of time. So Kelly Wiepert has another question about those kits are managed by you, by your staff or vendors?
No, it's by our staff. It's actually our central pharmacy staff that actually works also now inside the OR pharmacy.
And there's one last question about
No,
changing
Dr.
the
Fred.
blocks. Oh, we're
Sorry, I
done.
will have to interrupt you guys. No more questions. Time's up. Doctor. So anyway, thank you, Dr. Fred. Thank you, Dr. Sala. Pleasure to see you guys here. We will have to continue. Please go to the lobby, share there in the lobby will be great. See you.
Thank you.
Thank you. Bye-bye.
Thank you very much.
Okay.